So hello and welcome to the second podcast on cardiac auscultation. Now that we have covered the basics of the heart sounds, we'll move on to talk about some of the more common heart murmurs. So what exactly are murmurs? Well, murmurs are created by the turbulent flow of blood across stenosed or damaged valves. Murmurs can also be heard, however, secondary to other cardiac pathologies such as a septal defect or a patent ductus arteriosus. They can be heard during either systole or diastole, depending on when in the cardiac cycle blood flow occurs past the abnormal or damaged site. Before we move on to the exact order in which you should auscultate the heart, we will first take a look at how you can identify individual murmurs. There are two key aspects to identifying murmurs: the timing of the murmur and the site at which it is heard loudest. The timing part is often trickier and the bit that throws most people. To determine if a murmur occurs in systole or diastole, it must be listened to in relation to the S1 and S2. As we've already mentioned, you cannot reliably tell S1 from S2 without palpating a central pulse, so always ensure that you do not hold your stethoscope to a patient's precordium without first making sure that you've located and are palpating the pulse. Remember that the pulse you feel coincides approximately with S1, so any murmurs that you hear occurring just after you feel the pulse and before you hear S2 are systolic murmurs. A useful tip to remember is that S2 can often be either masked by the systolic murmur or can be quiet, secondary to the pathology causing the murmur. This means that when you feel the pulse, you may sometimes just hear the S1 followed by the murmur, without clearly hearing the beat of the S2. Here is an example of the systolic murmur of aortic stenosis. Listen in particular to the heart sounds. The second aspect to identifying murmurs is to remember that murmurs from particular sites of pathology often have characteristic sites on the chest wall or precordium where they are heard loudest and that they radiate to. A commonly used phrase to remember these by is at the post-mortem, or ATPM. These are illustrated in the diagram on this slide. Aortic valve murmurs are heard loudest at the second intercostal space on the right. Tricuspid valve murmurs are heard at the fifth intercostal space on the left. Pulmonary valve murmurs are heard best at the second intercostal space on the left, and mitral valve murmurs are heard best at the apex. In addition to these basic sites, there are a few further sites and techniques to remember. Aortic valve murmurs, in particular the ejection systolic murmur of aortic stenosis, while heard best at the second intercostal space on the right, often radiates to the region of the carotids. You should therefore always auscultate the carotids on both sides while asking the patient to briefly hold their breath. This is similar to how you would auscultate for carotid bruits. In actual fact, a radiating aortic stenotic murmur will sound very much like a carotid bruit. Similarly, mitral valve murmurs, in particular the mid-diastolic murmur of mitral stenosis, often radiates to the left axilla, and so you should always extend your auscultation here. Asking the patient to lean towards their left side can help accentuate this particular murmur. The final manoeuvre that you should always ensure that you perform is for identifying the murmur of aortic regurgitation. Like mitral stenosis, this is also a diastolic murmur. However, unlike mitral stenosis, this is an early diastolic murmur rather than a mid-diastolic murmur. This means that the aortic regurgitant murmurs are heard immediately after S2 rather than after a brief gap. In order to hear the murmur of aortic regurgitation best, you should not auscultate at the aortic valve area, but should instead listen at the left sternal edge, or the area that you now know to be the tricuspid area, that is the fifth intercostal space on the left. In addition, learning the mnemonic RILE, that is R-I-L-E, or right inspiratory, left expiratory, will also help you. As we've already mentioned, aortic stenosis is a commonly heard systolic murmur. Aortic regurgitation, on the other hand, is a diastolic murmur. As the aortic valve is found on the left side of the heart, it follows from our mnemonic RILE that murmurs of the aortic valve will be best heard in expiration. Whilst this is often not required to hear the systolic murmur of aortic stenosis, as diastolic murmurs tend to be quieter than their systolic counterparts, it can be useful to get the patient to hold their breath at end expiration in order to accentuate this murmur. You can do this by asking the patient to breathe all the way in, then breathe all the way out, and to then hold it there for a moment while you auscultate. A further tip is to ask the patient to lean forwards while listening for aortic regurgitation, as this can accentuate the murmur even further. Listen now to the early diastolic murmur of aortic regurgitation. So now that we've covered the basics of identifying murmurs, we'll look a little closer at some of the most common murmurs that you may hear. Aside from the timing and site, another feature of individual murmurs is their character, or how they themselves sound. Before we discuss this, it's probably worth briefly mentioning what the 4 commonest murmurs that you will encounter are, and where in the cardiac cycle they occur. These are the systolic murmurs of aortic stenosis and mitral regurgitation, and the diastolic murmurs of aortic regurgitation and mitral stenosis. As we have discussed with aortic regurgitation, if you carefully think about when each valve opens and closes, then you can work out why a particular murmur is systolic or diastolic. Now let's go back to the character of the murmurs. Listen first to the systolic murmur of mitral regurgitation. If you listen carefully to this murmur, you'll notice that you can't really make out either of the heart sounds. This is what is known as a hollow systolic or a pan-systolic murmur. In other words, one that completely fills a phase of the cycle, in this case the systolic phase. It therefore makes a whispering whoosh sound. This is similar to the sound made by the regurgitant murmur of aortic regurgitation. However, with this, you can clearly hear the S2 before the whoosh of the murmur. This is known as an early diastolic murmur. Listen again to the murmur of aortic stenosis. The common systolic murmur of aortic stenosis is known as an ejection systolic murmur and has a distinct start and end point within the cardiac phase. If you listen to the character or quality and shape of this murmur, you will notice that it is harsher and is therefore easier to picture why this is a stenotic valve murmur, as the more sudden whoosh is caused by blood suddenly being forced through a tighter gap. Listen now to another stenotic murmur, that of mitral stenosis. The diastolic murmur of mitral stenosis also occurs in the middle of the phase. This is a low-frequency murmur, and this is why you must use the bell of your stethoscope to increase your chances of hearing it. It is also often preceded by a click, as the stenosed mitral valve gives way under building pressure in the left atrium and suddenly opens. A final point to mention about the character of murmurs is that a number of additional descriptive terms are often used to characterize murmurs. These include rumbling, a term often applied to the low-pitched mitral stenosis murmur, and machinery, a term often used to describe the continuous murmur of a patent ductus arteriosus. The loudness or intensity of a murmur can also be graded from 1 to 6 by using the Levine scale. In this, murmurs range from 1, the lowest intensity murmurs that are difficult to hear even for the experts, to 3, which covers the majority of medium intensity murmurs that can be heard even by inexperienced listeners, or the rather mythical grade 6 murmurs, which are considered to be audible even with the stethoscope raised above the chest. Remember, however, that the loudness of a murmur does not necessarily correspond with the severity of the valvular lesion. Very loud ejection systolic murmurs, for example, can be caused by a relatively minor amount of aortic stenosis, and on the contrary, very quiet murmurs can be caused by significant stenosis. So let's now talk about innocent and pathological murmurs. Particularly in relation to children, you may hear the term innocent murmur being mentioned. This is essentially what it says. It is a murmur that is not associated with any significant pathology and that does not need any specific treatment. There is unfortunately no easy way of determining if a murmur is pathological or innocent, but there are a few signs that may indicate one or the other. In general, physiological murmurs tend to be located between the apex and the lower left sternal border, have minimal radiation, occur during early to mid-systole, and have a crescendo-decrescendo shape. They will usually change intensity with positional manoeuvres, becoming quieter on standing and louder with squatting. A Valsalva manoeuvre will decrease the intensity of the murmur because the increase in intrathoracic pressure will decrease venous return, which will decrease flow through the heart and lessen the turbulence. Their character is often described as vibratory. Additionally, physiological murmurs are not usually associated with additional findings, such as an S3 or S4, which we spoke about in the previous podcast. Examples of such physiological murmurs are the flow murmurs that occur during pregnancy due to increased blood volumes in the mother. Do bear in mind that the general features of innocent murmurs that we have mentioned are not foolproof, and murmurs must always be interpreted in light of the rest of the clinical picture. So, we've already alluded to the fact that murmurs, and more specifically the pathologies that cause them, can have effects on the heart sounds themselves. These can be useful clues for determining both the cause of the murmur and in getting an idea of the severity of the pathology. In severe aortic stenosis, for example, the S2, and in particular the aortic or A2 component of the S2, is reduced in intensity. This reflects a severely stenosed valve through which little blood can pass. By contrast, systemic hypertension can lead to the A2 component being increased in intensity. Listen to the following two examples. The first sound is that of early or less severe stenosis. In this, S2 can be distinctly heard. The second sound demonstrates later stage or more severe aortic stenosis, in which the S2 is quieter. Here is an early aortic stenosis. And here is more severe aortic stenosis. With pulmonary hypertension, a loud S2 is also heard, with the P2 component of this being the cause of the increase in intensity. This can also occur with atrial septal defects, as there is a sharp rise and fall of the pulmonary arterial pressure. All these findings are another reason why you should take care to not ignore listening to the heart sounds themselves whenever you hear a murmur. So finally, here are a few examples of some other murmurs and sounds that you may come across during auscultation of the cardiovascular system. An atrial septal defect causes a systolic murmur. Listen to this murmur now. During systole, as the pressure in the left atrium initially exceeds that in the right, the blood flows from left to right in what is known as a left to right shunt. This blood then passes down into the right ventricle and is ejected through the normal pulmonary valve, producing a characteristic mid-systolic flow murmur. This murmur is best heard over the pulmonary area and can radiate into the back, as with the murmur of pulmonary stenosis. As mentioned in the earlier podcast, a characteristic feature of an atrial septal defect is the thick splitting of the S2. This is caused by the right ventricle being continuously overloaded secondary to the left to right shunt. As the atria are linked via the defect, inspiration produces no net pressure change between them and therefore has no effect on the splitting of the S2. The S2 is therefore split to the same extent during both inspiration and expiration. This is called a fixed split S2. Small ventricular septal defects also produce an early systolic murmur that begins with S1 and stops in mid-systole when the ejection of blood continues and the ventricular size decreases, thus sealing off the small defect of the VSD. This murmur is characteristic of the VSD often found in children that is located in the muscular portion of the ventricular septum. Here is an example of the murmur of the VSD. The final murmur that we're going to mention is not strictly a murmur as such, but is actually known as a pericardial friction rub. This is caused by the contraction of the heart against an inflamed pericardium. Pleuritis, or inflammation of the lung pleura, in conditions such as pneumonia, can also produce a similar sound. Rubs, however, that disappear whilst the patient holds their breath are more likely to be of pleural rather than pericardial origin. The cardiac friction rub is usually continuous and is heard diffusely over the chest wall. It is accentuated when the patient sits up and leans forward, and may also be accentuated during inspiration. It is characteristically likened as being similar to the noise made when walking upon freshly laid snow. Listen to this murmur now. So, in conclusion, remember that the key to improving your auscultation skills is to practice. Try and listen to as many murmurs as you can. Good places to find patients with interesting heart sounds and murmurs include the cardiology wards, the care of the elderly wards, and preoperative cardiac surgery wards. Well, that's it for this edition of the Joint Revise for Finals and Podmedics tutorial on the basics of heart sounds and murmurs. We hope that you found this tutorial useful. Thanks for listening, and see you soon.